Welcome to today's Disability Awareness Talk. We're lucky to have Dr. McInnis with us here today, and Karen's going to introduce him for us.
Karen Kurtz. Dr. McInnis is the director of the Heinz C Prechter Bipolar Research Program, and he leads 30 staff in projects that are focused on bipolar disorder. His training is diverse, from Canada, Iceland, London, UK, Baltimore at Johns Hopkins, and he is a recognized international expert. He's at the U of M since 2004, and he has established a longitudinal study on bipolar disorder with a focus on detailed clinical and biological outcomes that research this devastating illness. He collaborates nationally and internationally in many programs of bipolar research. He's actively involved at the U of M, including mentoring of faculty and research staff on clinical and translational research in bipolar disorder. This is Dr. McInnis.
Thank you. Thank you very much. Behind the, there we go. View. Well, thank you very much for the. No, can you move that up there? So I can, yeah. Well, thank you very much for the opportunity to come and talk about bipolar disorder, and I'm so glad to have Billy here with me today. We had a conversation about a week or so ago, I think, Billy, just to talk about.
I actually have bipolar disorder.
And so we're going to be having just a conversation after the presentation. So what I'd like to have is a little bit of an interactive conversation. Here I have a handful of slides that I'll use to talk around. And excuse me, sometimes I have to clear my throat this time of day. Okay, so the first question that people ask is, what is bipolar disorder? How do we think about what bipolar disorder is? And so I have a, this will work. There we go. So I like to think of bipolar disorder as really a human condition that really is defined by pathology of energy. So the energy can be just too much or too little. And so if you just think of it in those terms, it's easy to have a more clear idea as to what is truly going on. Early in my career, when I was learning about the human condition, the human illnesses, and I saw an individual, worked with an individual who had bipolar disorder, and the most profound experience in seeing that individual was the sheer amount of energy that that person had. And the amount of energy was just, to me as a young doctor, just incomprehensible. The person did not need to sleep. They were just going literally 100 miles an hour constantly. And their mind was going fast, their whole body movements were going, everything was charged up and just revved to the, to that mad degree. So when we think about bipolar disorder, and see on the screen here, when we talk with students, young doctors in training, we often just describe it in this sort of sinusoidal wave pattern. So you have periods of time when the energy is really up and you see the person jumping in the bed of flowers, and then periods of time when the energy is just down, down, down. And you see the person there sitting in the corner, just with no energy, unable to do the simplest of things in self-care. Many persons will say, I get so depressed that I just, the thought of getting out of bed and getting into the shower is overwhelming to me, and I just can't even possibly think that I could, possibly do that. And so everything is slowed down, everything, even the gastrointestinal tract, everything just seems to slow right down. That person becomes constipated and just, that in the whole process of thinking is just like struggling through molasses, and the person just says, I can't even think about how to form a sentence. So that's in the classical way that we think about it, and we teach our trainees and residents. Now, what happens in fact? And Billy and I are going to be talking a little bit about this, later on. As you see on the lower right there, you see, should be blue, but I think it's kind of a purple color. And you see the red there. And what is on the left-hand side, what's called the y-axis, the vertical axis, is really a representation of the symptom severity of the depression symptoms in red, and the manic symptoms in this kind of purpley blue color. And the lines along the bottom are, weekly designations. And so this is over a course of 1 year of an individual who is in our study and who lives with bipolar disorder. And I have the great privilege of being married to my wife, who's a theoretical physicist, in addition to being an oncologist. And so whenever I'm in trouble with my data, I show it to my wife and say, what can you make of this? How do we understand this? 3 seconds, she just said, oh, you've got a bunch of dynamic states going on here. And so this is, really, what do we think about with the condition of bipolar disorder? For many an individual, not all people with bipolar disorder have this configuration, but many, I would say, probably in the range of a third to half of individuals with bipolar disorder have this up and down in an ongoing way. And this makes the illness challenging to manage, and we have to work with the individuals, work with the treatment team, work with the case management individuals at CMH and other entities. But what I want you to appreciate with that on the right-hand side there is the ongoing dynamic nature of the experience of bipolar disorder. And so moods are going up, moods are going down. And so you can ask yourself, from a medical perspective and a psychological perspective, when someone's mood is going up and you have a symptom severity rating, but the trajectory of the mood change is such that it's in a particular direction. So it's not exactly the same state, if you will, as if the mood is going down. So it's a very dynamic kind of condition. So one of the things that we have been working on at the university is to try to identify strategic ways that we can anticipate change. And one of the projects that we have ongoing, which I'm not going to talk about here, just to sort of give an overview of it, is derives from a period many a decade or two ago, when one of the family members of one of my patients said to me, he says, Dr. McInnis, 2 weeks ago, there was something going on. There's something about the way he was talking that I said, this is not right. There's that. And I just couldn't quite put my finger on it, but it was just in the way he spoke. And so we then went to the engineers at the University of Michigan and said, can we capture speech samples and determine, from the acoustics in the person's speech, whether there would be predictive ways to do that. And so that was 12 years ago. We started the project. Project is still going on. We're humbled, of course, at every stage of the way, because we thought things would be a lot easier than they were. And guess what? Life is far more complicated at every level in that. And it's, there's all kinds of contextual things that occur and determine how a person responds, how a person interacts, and what their mood is at the particular moment, what the nature of the perturbation, in the environment is, so people will, you've heard the expression, fly off the handle and that. And so people react in different ways. And so it's a fascinating and challenging situation to work in. Now, many of you have heard about, people that talk about affective disorders, right? So we talk about, someone's got an affective disorder. And so what is affect? Affect is a very interesting word in that. And so the best way to really appreciate the concept of affect is to think about it in the context of affection. And this affection is something that we as humans, we receive and give affection on a daily basis. And so how can we understand the concept of affect? So if any of you have seen the Oxford English Dictionary, which is no longer in print, but back in the day, it was like 10 feet of books that are very thick and deep, and that affect and its derivatives comprise about 4 pages in the Oxford English Dictionary. So it's a very complicated and fascinating word. one of the best ways to think about it, and I've got the obligatory gray-haired old white man, picture there. But Emil Kraepelin was a psychiatrist that was incredibly influential about 100 years ago, and his ideas and thoughts still permeate through all of the ways that we think about mood disorders and psychiatry into this day. And he saw affect as having three components. So it has, so thinking, and it's easy to think about it in the context of affection and a parent looking after the child. And so we have the volition, the drive, to take care of it, that. And so we have we have the will, the drive, and the energy. And it's volition is a complex concept in many ways. But, and also we have, emotion, we have the love for our children, and we have, that, and we have the intellectual component of it. We say nice things and think nice thoughts and, that sort of thing. So thinking about affect and affection in this particular manner gives a very helpful context around which to understand the term. So what we're doing, and I mentioned, we're thinking about international collaborations, and we're trying, to get together, groups of scientists worldwide to understand and to put context and organization around the term of affect. And so we have emotion. You can look at, the package of emotion. We have happiness, sadness, and in a variety of different emotions on that. Volition has energy, it has will, it has a number of different terms from a philosophical, perspective. And intellect can be easily broken down into fast and slow thinking, positive and negative thinking. So it's very, very easy to think about it in that way. So we're trying to think about how we can organize our thinking around affect. So I'm emphasizing this because when we talk about mood disorders, we talk about affective disorders, we really need, and when we train our junior doctors and people who come, so what exactly do you mean by this? What is the example of this? When you say someone has an affective disorder, what do you mean? Tell me what you're seeing and then describe what you're seeing. Now, one of the most challenging things, and I think Billy, you and I talked about mixed states a little bit. And so we'll be talking a little bit more about your experience with that shortly. But this concept, the way that Kraepelin conceptualized affect is really helpful when we think about the mixed states. And many of you that are familiar with people with bipolar disorder will have heard, somebody so-and-so and what of being in a mixed state. So you say, well, what's that? And I, as a junior doctor, I would, so what is affect anyway? What is a mixed state? What is it? And they say, well, you got symptoms of mania and depression. They're saying, well, that's not very helpful at all, just to say that. I mean, how can you have that? So thinking about affect and these three elements of affect that can cycle in sync. So when everything is right at the top, we have high volitional states, lots of energy, positive emotions, what to do, things and thoughts going fast and very positive. And this is just this euphoric energy. The opposite being in depression, where energy is low, mood is, emotions are low, and the thoughts are, kind of negative and slow. So what Kraepelin pointed out was that these elements of affect could cycle out of sync. And so.
Just going to this, so you're.
Okay, yeah.
Looking for the perfect spot.
Moving around. And somehow I see the end or whatever this, we translated this from PowerPoint into Google presentation. And so there's a little bit of squishing, the motion lost an end. So think of it, so think of it, and many of you who have knowledge of individuals that live with bipolar will recognize that there are some conditions and some situations where there's just a high energy state. Very high energy with low emotions, dysphoric, negative kind of content, of thought, but lots of energy. So what do you got? You got somebody with a lot of energy knocking around inside them and a very negative attitude, very unhappy, very dysphoric. And this represents one of the most dangerous, critical states in bipolar. So I think that there are a lot of untoward things that occur, a lot of aggression, a lot of impulsivity, a lot of behaviors and actions that the individual subsequently comes to regret that occur in this mixed affective state. So this is the most common of the mixed states. And so there are other, conditions in the mixed states that you can have, high level emotion, just right on the top, and low energy and low, kind of, and that. And then this is called the manic delirium. I've seen this kind of a condition twice where the individual is just in a euphoric state, lying in bed, but was effectively paralyzed, but you could see from the facial expression that it was there. So the other states do occur, but this is the most common of the mixed states. Yes.
How common is bipolar overall?
Oh, yeah, thank you. So bipolar disorder and bipolar 1, the classic mania is around 1% of the population. When you include bipolar 2, which is a less severe or less intense manic energized state, then that adds another 1%, so it's a total of 2%. And then if you think through what we refer to as the spectrum of it, so there are individuals whose moods go up and down a lot and they may be unstable, and that adds another 2%. So that in this, thinking of bipolar disorder across the spectrum, it affects around 4% of the population.
And is that adults?
So that's thinking about the adult population, there are many challenges in the pediatric population to think about what that percentage is. It's really not entirely clear. The children that have these unstable moods in their in their childhood and maybe just around past puberty. This is called, I can never remember the full name, dysregulated mood disruptive disorder or something. That there's a DMDD. And the thinking was that these individuals, these children that had this mood instability as in their childhood would go on to become bipolar disorder. But that one of the larger studies indicated that in fact these individuals went on to really just be major depressive disorder and not bipolar disorder. So there's a lot of debate, in the child and adolescent domain. But there are children that have the classic bipolar in terms of the mania and the depression, and in childhood, but it's much more rare. But mood instability is common amongst children with temper tantrums and in that.
Yeah.
Yeah. So the purpose of this slide here is to and the method in showing the primary colors there is the following. So if you think about the concept of affect, of emotion, volition, and intellect, and think about them in the context of the primary colors. And so how many colors are there in our spectrum? This is, the three primary colors, but they combine to create how many colors? A lot. Yeah, that's a scientific number, a lot. So likewise, to think about these modules of emotion, volition, and intellect, and the variability that you can have in that, it's easy to appreciate that the range of mood experiences that an individual can have is likewise a good number, right? And so we're tasked, in medicine and psychiatry to try to come up with a way of describing that and having a word for each of these emotions. And that's as challenging, or these affective states. And that's as challenging as coming up with a term to define each and every one of the combinations of the primary colors, right? And we have, one man's magenta is another man's purple, if you will, and so this is the one of the fundamental challenges. And so one of the things that we're doing in this collaborative work that we're doing is saying, okay, can we assign a particular number to each of these elements in the range of this affect, and therefore start a process of creating the system that computers can recognize in order to start to help us understand and create subgroups of individuals with, in the various different mood states. We don't know if it's going to work or not. We don't know if it's going to help us. But much of the research that is done to date, you will know, it's just that, okay, for the people with bipolar 1 disorder, the people with bipolar 2 disorder, people with, major depressive disorder, we're going to analyze that group. And that's why I explained to you that those high-level diagnostic categories, there are so many different variations of the individual experience in these larger top-level groups. And so we ask a question like, what is the frequency of bipolar 1 disorder? Well, it's, in that, but many a person, with bipolar 1, is not exactly the same as another person with bipolar 1 or a person with bipolar 2. There are many different patterns in this. And so we're faced with a, kind of an interesting complexity of of understanding the illness. And so, and it's very similar to thinking through what sleep disorders are. And so the top level here, top one, so this sleep disturbance, I'll just put this right in here. Sleep disturbance, there's a instrument that we use to evaluate individuals called the Patient Health Questionnaire 9-item, PHQ-9. And these other ones here, the MADRS, the Montgomery-Asperger Depression Rating Scale, the Hamilton Depression Rating Scale, and the Quick Inventory of Depressive Symptoms, here. But PHQ-9 follows what we know as the DSM. That is our diagnostic Bible, if you will. And all it asks is, does the individual have difficulty falling asleep or staying asleep or, any kind of, sleep disturbance. So it's very vague and inclusive. So what we need to be able to do is to put more granularity in our understanding of sleep disturbance. And so you can have insomnia. All of us have some. Nobody escapes a night of insomnia, and so that you can have difficulties with sleep onset, falling asleep, and you can have difficulties staying asleep. People note that they wake up, frequently, during the night, or sometimes there's an awakening in the morning and just unable to get back asleep. So there are ways of increasing depth and granularity in our understanding of the phenomenon that the individual experiences. And so hypersomnia, it refers to the individual, kind of sleeping 10, 12 hours a day, and sometimes they'll sleep multiple, times during the day. And this is not infrequently found in bipolar 2 disorder, where individuals say, I just can't get out of bed. I'm just sleeping, all the time. So, with this slide, I'm just showing you the challenges that we are faced with and the work that is going on now to try to put more granularity and understanding in these features. Now, I mentioned to you earlier when I was talking about bipolar disorder and the energy and that. And so there are individuals at least often in the earliest stages of mania, that there's a decreased need for sleep. And somebody will say, amazing, I only need an hour of sleep. Or I got away with, and they just think, I just feel great. And, up there, when, the spouse is sleeping and then say, and then somebody will get up and they'll be cleaning a house through the night or doing, things that, I gotta clean the house, or I gotta this, or I gotta go do some, that, or I've got to remodel a bathroom, and, and just all this, and so that, the amount of energy that is there, it disrupts the need for sleep. And this goes into the understanding of what bipolar disorder is and in the context of the energy. And so cleaning, working out on the town, ideas, I just got all these ideas coming into my mind that really take me into, I've got one more thing I have to do, I talked to a person the other day. He said, well, I got this OMT. OMT, so one more thing, and so, and so that, to come up with. So, so one of the things that people are often, ask about is, so what do you do with, individuals with bipolar disorder? Well, the thing this is the classic categories of medications. I think top of the line there are the mood stabilizers, lithium, lamotrigine, valproate, carbamazepine. The antipsychotic medications, it's a class of medications that are really, I think, poorly, or it's, I don't know what, it's just a word. So we use medications in this so-called class to treat a variety of different things in bipolar disorder, including the depressive phase in bipolar disorder. Some of the newer medications in this class are becoming increasingly more popular. We're very cautious. We caution people often on the antidepressants, and we caution people on the use of anxiolytics, the clonopins and the benzodiazepines. So many of you will recall Kurt Vonnegut, the author, and that he said, well, Kurt Vonnegut was known as saying, he said, the problematic thing with Valium is that it doesn't do any good unless you stop taking it. So he had some considerable experience in that domain. And the other thing that people want to know about, what about the talk therapy? What are the psychotherapies? And so one of the feature of the psychotherapies is that the common element of them is the relationship between the therapist and the individual living with the condition. And it all involves around working together, focusing on what the strategic things would be. So they have cognitive and behavioral therapy, and that's identifying, bad thoughts. I am a bad parent. I'm a bad carpenter. I'm a bad whatever. And so the CBT approach says, well, what is the evidence that you're a bad parent? Sure, you made a mistake. Everybody makes a mistake, but and then the interpersonal, thing is that, well, let's talk about how you get along with your boss, spouse, friends, and what kinds of things are you, doing there. Interpersonal and social rhythm therapy is relatively, it's new in the past couple of decades, I think. And it really focuses on identifying social and rhythm, the time of day we do things. And so one of the most important things that we do, to keep a rhythm, in our daily life, well, it's getting out of bed. Turns out, having a regular wake time, getting out of bed is good. When do you start your day? Is, interacting with the world. I mean, that's another important thing. So, people use the example, gets up at 7, starts meets the world in terms of doing whatever the task that the individual is, focused on, whether it's work or volunteering or just getting things around the house and done, interacting with it. And then the evening meal. That's another an important kind of marker in the day, and then the time to bed. So there are 4 times, 4 points during the day that are really, really important. Individuals who live with bipolar disorder, all of a sudden they say, just getting such a good amount of energy, at 10 o'clock at night, it's like, gotta get all this stuff done. You talk to a student, so I need to get my whatever done, and that. So an individual with bipolar disorder will all of a sudden discover that they've got this burst of energy and it just came out of the blue. I gotta follow it. So they work, through the night into, 2, 3, and 4 in the morning, and then what does that do? It sets everything, off, and it puts in place a cycle of, instability and that. So that's difficult. So we counsel people with bipolar disorder to succumb to that kind of activity. DBT, dialectical behavioral therapy, that is a kind of a training kind of therapy where people are taught to recognize the various different emotions that they're experiencing. And so if you're feeling a lot of anger, somebody cut you off on the high, whatever, probably the person didn't realize they cut you off, and they're worried about getting to their appointment, and that it had nothing to do with you, and that. And so it's kind of reframing one's own emotions in the context of the way the world interacts with you. Social interventions, but that's the thing that's case management, and very frequently the community mental health teams are really, really terrific at helping with that and getting individuals into what we have to, connect about housing, you have to connect about, figuring out how to, make sure that you can get the most out of your job or the, protected work environment, such as the case, may be. So anyway, so that is kind of wraps up, and so one of the things that I think is incredibly helpful is to appreciate that in psychiatry, you know, we have a lot in common with the physicists in actuality, and so the physics, you know, when they're studying astronomy, they point out, you know, that the universe is a series of approximations. And, you know, I don't know, when I was in school, we still had slide rules. I mean, what is just not all that, you know, accurate, you know, and then, so we were so pleased to get these calculators in. But then, you know, then thinking about physics, I watched the movie Copenhagen a number of years ago, and I was just enamored by that movie. And it was the relationship with Niels Bohr and Heisenberg, you know, then, and so Heisenberg's uncertainty principle states, you know, the more that you know about a particle, you know, the more that you study the particle at a particular moment in time, the less that you can know about the momentum of that particle. And the applicability to psychiatry is profound, because the more that we can know about what the individual is at this moment, the less that we appreciate and understand, you know, where the individual is going, or the trajectory that the individual, you know, has been along. And so it's thinking through, how do we have sufficient information, you know, about the here and now, and then to develop an idea and a practical understanding of, you know, where the individual has been, where they are going, and how do we maximize the potential of each and every individual who lives with bipolar disorder. I mean, each of the specialties in medicine, they're all focused on their conditions and that. But I'm worried about bipolar disorder, and that's been my career.
Is this something you can acquire, or is it something you're born with? Does it peak at certain times of your life?
Yeah, so thank you for that question. So there is an increased family history of individuals with bipolar disorder, and so the statistical risk, which is really at the level of a population, about 5% of individuals with bipolar disorder. There's a 5% risk in the siblings and the first degree relatives of someone who has bipolar disorder for developing bipolar disorder. There are individuals who develop the illness that we have no understanding as to why they developed it. We have no understanding and no knowledge as to what happened. We can say, well, this followed in the wake of a significant stress. This followed in the wake of, you fill in the blanks, you know, what the stressors are. We all live in a variety of different stressors. And, you know, and what I do is I acknowledge to people that I am reduced to being a student, you know, of this illness, in fact, that I can't say why this person developed the illness. If the person develops the illness and they have a mother or some brother or a sister that has the illness, then I can say there's a high degree of likelihood that there are ongoing genetic factors that are contributing to the evolving, you know, mental illness that the person has. There are things that can exacerbate bipolar disorder, and you know, and that includes, you know, substance use, you know, kind of adversity is, you know, childhood sexual abuse is more common in the history of someone with bipolar disorder as you know, as compared to people that don't. But that is not to say that everyone who, you know, experiences substance use develops bipolar disorder. That is not to say that everyone who lives, you know, through adversity in childhood develop bipolar disorder. That's not to say that at all. And so therein, you know, lies the strategic way of thinking about it and understanding the illness in the context of the person's life, and putting the story together and helping us determine a trajectory that involves, you know, care, treatment, and life in general going forward.
So if someone comes to you and they've had untreated depression for a period of time,
Mm-hmm.
when they get back to a baseline, they're gonna feel more normal and stuff, so
Mhm.
they may feel like they have the higher energy,
Mm-hmm.
sleeping better, you know, regular routines. How do you differentiate that from a true like manic state for someone that's sort of lived with
Yeah, yeah.
mood change, you know, because they felt ups and downs.
Yeah, so, and so in that sense, the importance of identifying the various different moods that the individual has. And so one of the strategic things that I, teach the residents and the medical students is to really develop an appreciation for the range and the degree of mood states that the individual has. And so a normal mood state would have, 6, 7, 8 hours of sleep with the ability to function and do things that the average person would do. Whereas if all of a sudden, I just got this phase where all of a sudden I just appreciate that I am the best darn carpenter in the world, and nothing can stop me, and so, I get these P's where I get, and that. So it's really developing an understanding of the range and diversity of it. Now, one of the things that we've noticed is that, it's fascinating in many ways. So bipolar is both overdiagnosed and underdiagnosed. And so when we're evaluating students, and so you get a college student who's, just got a new girlfriend, just got that, and say, oh, feeling on top of the world, man. And so there's a little bit of wiggle room in that appreciation. And people are often very pleased and happy that their mood is back to normal. It's just, thank God, and they really want to go in that in. I think, Billy and I, we were talking about your very severe experiences, Billy. So what I wanted to do now is to, ask you, Billy, to share with us a little bit about your experiences with bipolar. My chair.
Yeah, well, for those who don't know, I was diagnosed in 2021 after having a severe bipolar episode. I had to be hospitalized. During that time, I experienced psychosis, which is essentially a detachment from reality.
What was the psychosis like for you?
Extreme paranoia and grandiosity.
What do you mean by paranoia?
Well, I was constantly doing this in front of doctors and nurses, even though I had no need, because I felt like, uh-oh. And
But you say paranoia. Sometimes people talk about paranoia, it suggests that people are out to do bad things to them. Did you have that experience?
yeah, or because I'm an offender, and that's what made it so plausible, was that I'm an offender, and so as a result, I thought, uh-oh, people are gonna do bad things to me, when in reality, there were other offenders on what we call the ward, and that.
Because that must have been a bit frightening to think that people are, out to do bad things to you.
Yeah, like, oh no, is they gonna send security at this particular hour?
Mhm. Yeah, and so you mentioned also, when we chatted, I think you mentioned that, your energy was pretty high too when you were in the manic state.
Yeah, from what I remember, my thoughts were racing at 1,000,000 miles an hour, and it was hard to have a coherent one.
Really? Because I've heard people say it was just like, if you had like a movie theater, and you just sort of speed up the thing, and things were just going so fast.
That's a good analogy.
Yeah, and it just, and you say you couldn't hold on to one thought.
Yeah, it was tough to have coherent thoughts, and I wonder if that contributed to the psychosis.
Well, it's hard to make sense of everything, it sounded like that.
Yeah, it was, and Harbor Oaks did a great job of maybe getting me to the right medication, but.
So tell me about how that happened. You said you were in Harbor Oaks, so it sounds like you went to hospital?
Yeah, that's the hospital I went to, is called Harbor Oaks, it's in Detroit.
All right. And how did they help you there?
Besides watching me while I had psychosis to make sure I didn't hurt anybody, they eventually got me on a combination of Rexall T and Prozac, which has been helpful as far as medications go.
Right.
I liken the effect almost to a vaccine, if that's a fair analogy.
Keeps you, sort of prevents some bad things.
Or it mitigates them.
Mitigates them, right. So another thing, I think you and I talked, and I don't remember whether you had the experience of hearing things when there were nothing, when nobody was doing, did you?
No, it was more like thinking things.
Thinking things, yeah.
When there was no evidence to think things,
Like things that, what kind of things were that?
like thinking the nurses were out to get me, when in reality I wasn't participating in my care.
Okay.
Because by being honest with those nurses, I could have made a lot more progress.
Well, I mean, it's kind of part of the challenge is just getting things on track. And it sounds, how long were you in hospital?
About 2 weeks.
2 weeks, okay. And then coming out of hospital, tell us a little bit about your experiences then.
Well, my dad was really worried for a while and the church got worried. I actually had to do some congregational care.
Mhm.
This church is great with that, by the way.
So the importance of community it sounded like that was really, really critical
Yeah,
in
and
getting your.
the first thing I did was enroll in DBT about a month later.
Okay, yeah, because I talked about the DBT. Tell us about what you learned on the DBT.
Well, the most important thing I've learned is probably mindfulness. The idea that my emotions don't necessarily have to be bought into, although that's something that they're covering more in depth in ACT therapy, which is acceptance and commitment therapy.
So
And
mindfulness, let's just explain, what does mindfulness mean to you?
the art of living in the moment.
And we are living in a moment. So we're here today. It's Sunday, Sunday afternoon, and so we should be in a low stress environment, which we are, and things that we're just here and appreciating and understanding that we have the privilege of hearing you talk about what was the experience like of going through management and that. That's kind of
Yeah, and we observe, we describe, we participate in the moment. Now, that was definitely not something I was doing with psychosis, because I maybe was observing, but I wasn't describing or participating. I was so wrapped up in my own thoughts.
And so tell us about where so you have a wonderful community here and you live, do you have your own place that you live?
I still love my dad.
You still live with your dad? Okay, great. And how is your relationship with your dad?
It's okay. My stepmom, it's a little more volatile. It is what it is. I mean, right now it's real good though.
That's great.
And
how do you spend the day?
I go to the movies a lot and I go to class at CMH about 3 times a week, although right now it's 4 because I wanted to do ACT. I'll probably have to do ACT again just because self as context didn't make a lot of sense.
Yeah. So one of the things that I've heard many a person talk about is the challenge in coming to grips with the fact that one has the condition that one has.
Yeah, well, I'll be honest with you, I had a relatively easy time with it. First of all, in DBT, they teach radical acceptance.
Yeah.
Which is an intentional act of accepting a reality that I or another person cannot control.
Like somebody cutting you off on the roadway, for example.
Right.
You can't control that, right? And so that's, but what can you control?
The fact that you're not speeding.
Right, well, you're not speeding, but you can control your reaction to that, right?
Right.
And
But I mean, I also knew that.
just because somebody's being a silly bean and doing something silly, doesn't mean that you have to respond, right?
Yeah, but when it came to being diagnosed, I also knew that it made sense given my prior behavior. And that's a long story, but essentially it was like, oh, I have this. That makes sense.
Yeah. Yeah, I think that you're incredibly fortunate to have that, we call it insight. And so that insight just means that, one recognizes that one has anything from diabetes. I mean, we know many cases of, younger people that live with diabetes and they just get really annoyed that I don't have it, and they try to work and show the world that they don't have diabetes, and that is many a human condition. People will deny, it's called denial, right?
Yeah, growing up, my mom had bipolar disorder too, and one of the things she was in was denial, and eventually that denial led to her to stop taking her meds, which didn't do anybody any good.
All right. Yeah. So, when you talk with people that are newly diagnosed with bipolar, Billy, what do you share with them?
I don't really get much chance to talk with people that are newly diagnosed.
Or
But
if you had the chance to talk with someone who's newly
But if I had the chance, I'd tell them, if you're on any antipsychotics, take those because you do not want psychosis.
Right.
Probably the first words out of my mouth.
Really, was that frightening for you, was it?
Well, I just remember it being more surreal
Surreal, right?
and
Yeah,
having no idea that I was having delusions because I took my thoughts and I bought into them so readily and so easily.
yeah. So just for, to clarify, I think that around 50% of individuals who live with bipolar disorder will experience delusions. And delusion is defined as simply a false belief firmly fixed in the individual and unamenable at the time to any logic or challenge. And so.
Yep, that sounds right, that sounds about right.
Yeah, and so sometimes, and also sometimes in the more severe forms of it, individuals can hear voices, and then like somebody saying, do this or do that. You didn't have that experience.
No.
That's great.
So how do you differentiate that between like schizoaffective or schizophrenic?
Schizoaffective disorder is an excellent point because many a person who experiences psychotic experiences within the context of a manic episode or even a depressive episode, you will see that that individual is diagnosed with what's called schizoaffective disorder. A true schizoaffective disorder means that there are abnormal beliefs or experiences in the context of not having a manic or depressive episode itself. So someone who just has a residual, persecutory belief that that people are out to get him or her, even in the face of not having overt, kind of symptoms, that's the technical.
So the whole rest of the mood is very important.
Sorry?
The whole rest of the mood
Yeah,
is very important.
Yeah.
And,
Yeah.
okay.
So, so that's the, but it's, again, that's why I showed the image of the universe being a series of approximations. In that, so that's where that is. So that becomes the importance then of working with the physician or the treatment team so that that there's a formulation, it's called an understanding of what the condition is that the individual lives with. And things can change. Someone who lives with bipolar and had a very profound psychotic experience in the context of a mood disorder, there can be some residual, and then one person is like, well, at my worst, I was convinced that, this was back in the Cold War era, that the Russians were out, and every once in a while I said, I see one of those spies, downtown, it says, we look at each other, and we know. And that, and it didn't really bother the individual, so much, but it was sort of there in that residual way. And so, so that person, from our understanding of how we describe and understand these things, would qualify for the schizoaffective designation. Now, the fundamental problem is, as Billy knows, we don't have a blood test. We don't have any.
I know, that is true.
We don't have a definitive marker, either in neuroimaging or otherwise, to say this is what this is. And so I spent, and I don't know if many of you know what Huntington's disease is. And so that illness was identified as a genetic, and the genes were identified in 1983. And so it turns out, my gray hair, that's the year I graduated from medical school. And so there's a cohort of individuals in the scientific and academic community that were just convinced, okay, Gazella found the Huntington's disease gene, and so we're going to find this in bipolar disorder, schizophrenia, and all that. What happened? As you all know, so there is no one gene. There are hundreds of genes that each contributing a very minute amount. To the potential, but we don't even know that, for sure. We don't know what we don't know. And that, so the approximation of, the schizoaffective disorder is exactly that. Now, it's more than the schizophrenic illness is itself. So not infrequently, the individual is struck with schizophrenia in their late adolescence, early adulthood. And they deteriorate and they go into a level of functioning that is consistent at a lower level. and they may have any number of different ongoing residual symptoms. But the feature of bipolar disorder, and this was described in, the turn of the last century, is that, it's the cyclical, nature to it going up and down. And that's what defines this illness, really is the cyclical nature of it. Now, many a person, and you're not working, you're going to CMH, right?
Right, but I
Are
do
you on
work on the
disability?
calendar there.
Yeah, well, good. Do you get SSDI or is?
SSI, yeah.
SSI, yeah. So around 50%, and this is the thing that I was amazed about when I was learning about bipolar disorder, 50% of individuals really benefit from the social network that they have on the SSI, and with the recognition that we need to care for people that live with a disability. You look upon yourself as having a disability, right?
Right, yes.
Yeah.
I have autism as well.
Yeah. And so.
Sure adds another level.
And that's another level of it, in that, and so, so this is one of the, elements of bipolar disorder that we find incredibly fascinating, and, I think fascinating, it's not the right word, but incredibly intriguing. We don't understand it, so there are, probably, 30% of people with bipolar disorder, they work, they do things that they need to do, and many of them are incredibly successful. Another 20% are kind of struggling, that, and then there's the 50% that we really need to make sure that we have something in place to manage and on that. So the outcome, it's very difficult to predict what the outcome patterns are going to be. Very difficult to know in advance, when someone's diagnosed with bipolar, what their trajectory is going to be. And that's one of the humbling things about medicine.
Can I ask a question?
Yeah.
So if we have someone in our lives that we either they're in denial or we notice manic or depressive states, what's the best thing support we can give, or what's the, how do we respond in a compassionate way or helpful way?
Well, it can be very difficult at so many levels, because sometimes people says, I am not, and there'll be some, fists on the table and that, and so I think that the most compassionate way is to say, I am just concerned that, and then provide an example of, I'm concerned that you're not sleeping, I'm concerned that you're feeling low and depressed, I'm, just concerned about that, and what can I do to help? Then there'll be some other argumentative way that gets into it, but bringing this up with the individual, bringing this up with the primary care doc, bringing this up and say, there are options and things that can be done. Andy Dunn, who you met, and wrote the book. I mean, he went 15 years, struggling, with the illness and denying that he had it, and so there is this time period, it seems, that people go through that, that is a struggle, and there are no magic, interventions for that. What we see very frequently in our research is that, the individual, that's in their mid-30s, early 40s, say, I've been living with this dog for X number of years, and I want to give something back, and so therefore, I'm recognizing this is what I have, and and that I know that lithium is helping. I know that, and so they get into that mode. There's something that happens in the late 30s, early 40s to us all, that we come to grips with our past, we come to grips with our relationship with our parents, we come to grips with and just think things through in a manner that provides as Billy talked about, acceptance, therapies and that. So I wish I had a magic answer, but
Well, I know it's 12:30, and I know that you need to.
Yeah, so I'll need to get, but it's been, but you had one final.
Just a observation, I've known Billy since, he joined our youth program as a very young teenager.
Mhm.
And the lady that ran the program at the time
Mhm.
prepped the students to say that, Billy has some issues that, we want you to be sensitive to.
Mhm.
And I believe, and Billy would tell you straight up, that the support he got from that group, I think, helped
Mhm.
him through those periods. He's still involved, on this committee with the disabilities. He's also involved with a men's group that we started years ago. And he's been a very active member of that too, so he's got outside.
Yeah, and the thing that is important is community and inclusion, and so that cannot be emphasized enough. What we've found in our studies in terms of individuals living with bipolar disorder and in the workplace is that the experience of exclusion is one of the most malignant things that a person can experience, actually. And none of us like to be excluded, and then people will think, well, we don't want to make it involved, because maybe we're going to make it easy on them, and that, and so that, how many times have we thoughts about someone, and that is not the right thought. We said, you're welcome to be included, but how can we give the message that we want people to be included without putting undue pressure on them to partake in everything? And that is, that magic, is the dynamic of, the community, and that is just what happens in communities and.
Very cool. Thank you for coming, appreciate it.
No, it's my pleasure.
Thank you.
Thank you. So I'll let my wife know that,